Hi, everyone. Welcome to a conversation with Dr. Anthony Fauci. I'm Saad Omer. I'm the director of the Yale Institute for Global Health. And I'm delighted to welcome everyone to this first event for the Yale Global Health Conversation Series, a venue for our community to learn from and connect with innovative leaders in global health. And so in addition to YIGH, we are indebted to George Herbert Walker Jr. Lecturer in International Studies at the Macmillan Center. Today I'm joined I'm pleased to be joined with my co-moderator, Robert Bazell, who's an adjunct professor in the Department of Molecular, Cellular, and Development Biology. And before his arrival to Yale in 2013, he served for 38 years as Chief Science and Health Correspondent for NBC News. So Bob, welcome. As a reminder, all attendees have their volume and video muted, but we are eager to incorporate your questions. You can simply submit those using the Q&A feature in Zoom. We are also streaming this session on Facebook because due to Dr. Fauci's popularity and the topic he's covering, we exceeded our Zoom license fairly early on. So Facebook is our spillover. I think it's a testament not just to Dr. Fauci's gravitas, but also the importance of science in this unique moment in our time. So now let me introduce very quickly our distinguished guest, Dr. Tony Fauci. He's the director of NIAID, the National Institute for Allergy and Infectious Diseases at NIH, so he's an exemplar for an administrator scientist. He is one of the most productive biomedical scientists alive of our time, and has contributed substantially not just to the science, but also to policy. He was instrumental in some of the most successful public health initiatives, including helping design PEPFAR, among other things. Welcome, Dr. Fauci, formally to our conversation series. It would be great if you could provide an update on the current situation with COVID-19, including where we are in the development of therapeutics and vaccines, and a very brief update, and then we'll start with our formal questions.
Thank you very much, Dr. Omer. Thank you for having me. It's a pleasure to be here. So I wish I had a more positive report on where we are right now, but unfortunately, the reality is right in front of us. We're in a very difficult position regarding the dynamics of the outbreak in the United States. As you well know, we've had a very rocky course with a real bad northeastern part of the country, dominated predominantly by the New York metropolitan area, which overlapped a bit into Connecticut, where about 40% of all the infections in the country were dominated coming out of the New York metropolitan area. When that cooled down a bit, we saw the rest of the country start to catch fire. And one of the things that's important is that when we had a blast of patients, and then it would come down, we never got to a baseline lower than 20,000. And then when we got down there, we decided as a nation, we were going to try and open up the economy with some proposals for some, I believe, very reasonable guidelines for gateway in phase 1, phase 2, phase 3. However, the various states throughout the country adhered in a very variable and disparate way to the guidelines, leading to a surge of cases dominated by the southern states, Florida, Georgia, Texas, Arizona, Southern California, so that we had a surge of cases that went up to about 70,000 per day, and then came back down to around 40 and was stuck at 40 for about a month. And then now, much to our dismay, with the colder weather coming in the cooler months of the fall and soon the colder months of the winter, we're seeing over the last couple of days the highest per day number of cases that we've seen in the entire outbreak, 83,000 over the weekend. This is a very precarious position to be in as we go to the cooler months with more indoor activities versus outdoors and the upcoming holiday season. Superimposed upon that is the issue that when you look at the map of the country and you look at the uptick in test positivity, it is really diffuse with about 30 states or more having upticks in cases, which means the daily cases are going to be even higher than they are now. And as I said a moment ago, and I'll repeat it, that is disturbing to me is that I was hoping that we could use the summer months to get a grip more on the outbreak so that when we enter into the cooler months, we'll be well positioned. We're not well positioned. So unfortunately, that's a sobering news summary. However, on the other side of the coin is that things are looking quite positive in the arena of vaccines. As many know, it's been broadly advertised that there are 6 candidates that the United States government is very, very strongly supporting, either from a developmental or an implemental standpoint regarding clinical trials. 2 of these right now started phase 3 in July 27th, and 3 others soon thereafter. So we have 5 candidates in phase 3 trials. The ones, Moderna and Pfizer, that started in July 27th are now virtually fully enrolled, and we should start seeing data from the standpoint of number of infections in either the placebo or the vaccine arm very soon, so that we predict that by the end of November, the beginning of December, we will know whether we have a safe and effective vaccine. And I'd be happy to discuss that during the chat, but I feel cautiously optimistic that we will have safe and effective vaccines that will come to roll out by the end of the year, the beginning of this coming year. Finally, in therapy, we have reasonable good therapy for advanced disease. For example, the dexamethasone study from the UK clearly showed a big survival benefit for people on ventilators or requiring high flow oxygen. Remdesivir showed an increase or a decrease in the time to discharge from the hospital. And currently there are a number of trials now with things like convalescent serum, immune globulin, and importantly, monoclonal antibodies, which everyone is paying a lot of attention to. I would say in one final note, we need to do better in getting more therapies for early infection. In other words, to keep people out of the hospital, as opposed to mitigating their course once they are in the hospital. So the direction that's going to be pursued very aggressively in the next few months is looking at what we can do early on as a treatment in the course of infection. So I'll stop there, and I'd be happy to answer any questions again in any discussions.
Good. So I'll start with the first question, and then Bob and I will alternate, and then we'll take audience questions and student questions. So the first question is, what could surprise us related to the development of the COVID-19 vaccines? What are we not actively thinking about? You have a ton of experience with HIV vaccine development, of leading and informing that program, and many others. Is there something that we are not thinking about, as a field?
Well, I wouldn't say we're not thinking about it, Dr. Omer. I'm saying that we hope it doesn't happen.
Yeah.
That is, there's no guarantee that vaccines are going to be successful unless you do and complete the clinical trial. As I mentioned, I'm cautiously optimistic that we will be successful based on the rather encouraging data from the animal models, as well as the phase 1 data in these trials, which induced robust antibody responses to the level equivalent to, if not better than, convalescent plasma. The big open question is the durability of the protection. We know with coronaviruses that protection is not strikingly durable, as we know from the recurrence of common cold coronaviruses repetitively year after year. Even with the exact same molecular virus, you can get reinfected. So that's one of the concerns that we have. The other one that we want to hope we don't see, I don't think we will, but we've got to stay heads up for it, is enhancement caused by the vaccine, where you vaccinate someone and you get a suboptimum response, which enhances when the virus binds to the antibody, you get a difficult response. I think we're covering the bases. We have 3 separate platforms. We have messenger RNA platform. We have a variety of vectors, including adenovirus and VSV. And we have the standard tried and true recombinant protein with adjuvants. So I think I have all the bases covered. I hope we don't have any negative surprises.
Great. So Bob, do you want to take the next question? Do you want to ask the next question? You're on mute.
You're on mute, Bob.
Sorry about that. Good afternoon, Tony.
Hi, Bob. Nice to see you.
Good to see you too. Everybody on this call might not know that Chris Grady is your wife and a prominent bioethicist, and she recently convened a panel about what many people were thinking might be a very crucial question if a successful vaccine comes along, which is, would it be ethical to continue the placebo groups in the vaccines that are farther behind in the pipeline? Where does that issue stand now?
You know, it stands still open for significant discussion, Bob, but one of the, I think, core principles that were spelled out and most people agreed, it really depends on what the level of efficacy is and what the availability of vaccine for the general community is. If you only have a couple of million doses that you're not going to be able to distribute, so you wouldn't be depriving the people in the trial from the vaccine because they wouldn't be getting it anyway. And importantly, how effective is it? If it's 98% effective, that's one thing. If it's 70, 75% effective, that's another. So if you have a moderately effective vaccine and very few doses, most people feel for the good of society, it is best to keep the trial with a placebo arm in it. Only if you have a lot of doses and a very high efficacy would you then might want to switch to a breaking the blind and then having the other studies do in non-inferiority studies, which I don't think is going to happen because the VRBPAC committee met and they were very much in favor of, even if you get a mild signal in the first 50 or so points of efficacy, that you continue the trial in an unblinded way, both for safety and for efficacy. So there's a good deal of sensitivity about that in the positive way.
So I'm glad you mentioned the VRBPAC meeting. That's for the audience, this is the advisory committee, independent advisory committee to the FDA. And it was, I think it must have been the most watched meeting of VRBPAC. It almost had the thrill of a reality show there, but with a lot more science. And so, yeah, so I'm glad you mentioned that. One question that is coming from our audience, and I think that's the most frequently asked question that I am asked and anyone else who has worked on infectious diseases has asked, and I'm sure you have, I know that you have been asked before, but the most frequent question is that when do we think life will get back to normal? And the person who asked that question put normal in quotes, etc. So would love for you to sort of elaborate based on what you know as of October 26, 2020.
Okay. So you're right. I get asked that question all the time. And the answer is I don't have a crystal ball to say exactly when, but I do have in my mind what would be maybe a little plan or a roadmap of how we're going to gradually approach a degree of normality that might not be normal as we knew it before December of 2019. Is that by the time you get enough vaccine distributed throughout the country, and that will depend really on a couple of factors of what the uptake of the vaccine is. We have a number percentage right now in the country who are very skeptical about getting the vaccine. If we don't get good vaccine coverage, even if it's a pretty effective vaccine, it's not going to have the effect that we need, namely decreasing the incidence of infection in the country to such a low level that people could start doing things as what I call approaching normal. I want to make one point, Omer, that is really important, is that I don't think for quite a while, at least a year, that we're going to be able to completely abandon some of the public health measures that we're doing now, such as wearing of masks, keeping distance, avoiding congregate settings. If you get a good vaccine and the incidence and prevalence goes way down, then you could start gradually marching into things that are more normal. What do I mean by that? Restaurants that are at maybe close to full capacities, finally opening up theaters and opening up venues of entertainment that people can go to. But to say that once you get a vaccine, we're going to be free to do whatever we want, that just is not going to happen, I would imagine, at least through 2021.
So I guess that in that time, you'll be able to go to a Nationals game and I'll be able to go to an Orioles game. One of us is likely to be more disappointed than the other, but that's a different story.
I think so.
So Bob, your question?
Yeah, one of the things, Tony, is that in this, as you well know, you've become one of the best known people in America and probably the world. And as a symbol of science versus political pressure, how long, if at all, this is another crystal ball question, will it take to untangle that, what many see as a battle between science and politics?
That's a great question, Bob. It's not going to happen overnight. Whether or not you have a change of administration, it's not going to just go away. I think it's something that we need to deal with regardless of how the election goes, because there is a core feeling among some people of an anti-science, anti-authority pushback on what people feel is being imposed upon them by individuals who think they know more than them. And I think that that's something that as a nation, we really need to grapple. And people are now writing essays and books about that, about how we have such a divisiveness in society. And in fact, the divisiveness includes a divisiveness about what the role of science is and what the role of truth and investigation and data. And then we're dealing with things right now that are so disturbing, conspiracy theories, things that have absolutely no foundation in reality. It's so antithetical to what the scientific process is that we've got to deal with it. It's here and it's not going to go away in a month or two or three. I think we have to start dealing with understanding why there are segments in society that are so anti-science and try and engage them as opposed to staying so separate and almost like an enemy of each other. It should not be that way, obviously. I mean, I know you as a scientist and all of us as scientists are very disturbed at that, but we really got to reach out and see if we can mitigate that a bit.
Can I just ask a quick follow-up on that? You're talking to what would be defined as an elite. This is a university and scientists who, for the most part, agree that the science should be followed. I know you've been enormously busy, but have you thought about what specific things we can do to try to change that perception and that, it's such a challenge, as you point out.
I'm not so sure I can give you the 1, 2, 3 things that we should do, but I do think that we cannot continue to be at odds with the other group, the people who feel that we are elite and feel that we are looking down at them. That is, I think, the core reason why we have the divisiveness right now. Like, people want to poke a stick in the eye of the elite because the elite have in many respects disrespected them. We have to figure out how we can get rid of that disrespect and get some sort of harmony in the country. It's very, very disturbing to see the intensity of the divisiveness. And Bob, I mean, it's no secret now because it's been all over the newspapers how, as you said, that I've become the symbol of science and rationality and clarity, but that has created as many admirers as there are people who are actually threatening me. I mean, seriously threatening me. It isn't like, I don't like you. It's like, I have outside the door about 20 feet from now, federal agents that are guarding me. I mean, that's ridiculous. I mean, how preposterous does that in 2020 to have that? That's, to me, mind-boggling.
Yeah, so when we think of global health security, we never think of actual security people. We think of other kinds of things. So staying on that topic, I'm sure, I don't think you ever thought that you yourself will be part of an intervention that someone would evaluate. And we did exactly that, staying on this topic. So partnering with our colleagues across campus at Yale College, our political science colleagues, we ran a series of experiments, survey experiments, where we randomized people into giving them hypothetical scenarios where we said that when would the vaccine, if the vaccine was approved a week before the election, which is today, versus in December, and we said independently what would be their acceptance of the vaccine. And not surprisingly, there was, irrespective of political affiliation, although there were certain differences, the acceptance of the vaccine was higher if it were approved or authorized in December. But in another experiment, we found that whose endorsement would make people take the vaccine. And not surprisingly, your endorsement, and that's why you were part of our intervention, was the highest, inspired the highest level of confidence. But the other sign was that if, for example, the president and the speaker of the House endorsed it together, that would also have a positive, substantial positive effect. But your impact exceeded even the joint endorsement. And so just to set up, so this setup was to ask you that how any lessons for future science communicators that to earn this level of trust that you have earned in the middle of a pandemic. And it hasn't come since your appearance from January, because you had a cachet of several decades. And the reason I'm specifically asking this question is because I've always said that universities have a unique role. Universities outlast corporations, they outlast institutions, and often, as Oxford and Cambridge, they outlast republics or political systems. And so it is their unique responsibility to transfer that knowledge. So in that spirit, no pressure, Dr. Fauci, what is the lesson for future scientific communicators to build and accumulate that level of trust that you have accumulated?
That's quite a question, Dr. Omer. But I can just give you a couple of principles that I have abided by over the decades that I've been doing this. One is consistency based on the data. Admit when you do not know something. I mean, scientists who try to guess, that's bad. Anybody can guess as well as anybody else. Always go by the data and the scientific evidence and information. And when you're communicating, I think this may be one of the most important things, is that when you're trying to communicate science, the goal is not to show everybody how smart you are. The goal is to get people to understand what you're talking about. So often scientists, and I don't mean this in a pejorative way, they don't do it maliciously or even in an ego way, but when they're trying to explain something, they have this little bird inside them that tells them, I really got to look good. You don't really have to look good. You just need to be understood. And when people don't understand you, they then throw up their arms about science and they say, these people don't have any idea what they're talking about, so forget about it. So be consistent, know when you don't know something, don't be afraid to say, I don't know, and try to be understood as opposed to looking smart.
Tony, you just created a bumper sticker. Don't try to look good, be understood. I think that if nothing else comes out of this conference, I think that would be a very good one. I just want to add quickly here that I've known Dr. Fauci for a long time, and another definition of my career was he interviewed Dr. Fauci, because how many times have I interviewed you? But he was thrust into this position, but he handled it the way he did, not by accident. It took decades of enormously hard work, staying in the laboratory every day, visiting the clinic every day. And I on behalf of everybody here, and I think a lot of people in America, I want to thank you for that.
All right, thank you.
And I want to ask you a question, though. I did want to lead to a question, which is, when you take something like the Great Barrington Declaration about herd immunity, and people put it out who have MDs and PhDs after their names, and then there's people on the other side who trash it who have MDs and PhDs after their names. How do you deal with that when there's a dispute in the scientific community? It's not like Peter Duisberg versus the HIV deniers, not one person against the world. It's a group of people against maybe a larger group of people. But how do you explain the facts in a way that you get across the message you want to get across?
I think what it is, Bob, is a little bit of what I was saying about being understood. Instead of attacking people who have an opposite opinion and blowing them off and insulting them, what you need to do is to try and articulate to the general public why you feel that what is implied in that declaration doesn't make sense from a scientific standpoint based on data that we already have. And let me just give you an example. I noted that there are a lot of people who signed the declaration. And I think one of the misleading aspects of that is the declaration in and of itself doesn't say, but it implies this issue of herd immunity and what you need to do to get herd immunity. The two main tenets of the declaration are A, that we need to protect the vulnerable. That's for sure. We want to protect the vulnerable. There's no doubt about that. And in protecting the vulnerable, that we need to make sure that we have a situation where we don't shut down the government. So I can say I agree 100% with both of those tenets. We don't want to shut down the government, the country. We don't want to lock down the country indefinitely because that'll destroy the economy, and the so-called cure is worse than the disease. And two, we want to protect the vulnerable. However, implied in that is if you let everyone get infected and protect the vulnerable, the people in the nursing homes, the people in prisons and people like that, everything will be all right. The one fact that's missing in that is that 30 to 40% of the general population are vulnerable. So if you're going to let the infection just spread to let everyone get so-called immunity, in order to get 60, 75% of the people infected, there are going to be several hundreds of thousands of more deaths. That is not maybe, that is a fact. So if you can get people to understand that yes, we feel we want to protect the vulnerable, and no, we don't want to shut down the economy, but that doesn't mean that this idea of letting everybody get infected, don't do anything to prevent infection, is a good thing. And I think you just need to explain it in those terms as opposed to saying you're crazy, you don't know what you're talking about. Just talk about the facts, that's all.
So building upon that, whenever we have faced large public health problems, like the impact of tobacco, like HIV testing, it has been paired with a public health communications campaign or series of campaigns. And for those of us who follow these kinds of things, yes, there has been messaging at the highest level. You have played a huge role, but we are not seeing a conventional public health campaign around COVID-19. For example, working with the Ad Council, CDC working with the Ad Council and having specific goals outlined in terms of acceptance of behavior, et cetera, and so on and so forth. Going forward, there are signs of emerging vaccine hesitancy. Some of it is, frankly, not irrational in the sense that, looking at expecting a mainstream, unpolitical, non-political approval process. But on top of that sits the conventional vaccine hesitancy that focuses on the conventional drivers, if you will, of vaccine hesitancy. What do you think, and the National Academy has also recommended a national communications campaign around COVID-19 vaccines. Any thoughts of a large scale, appropriately resourced national campaign, and who does it, and any features as a frontline communicator of science in this pandemic. Any thoughts on that kind of a large-scale campaign? And that's an amalgamation of a lot of questions that we have been getting from the audience.
Yeah, I mean, that is actually in play to a certain extent, and will even get larger than that. And that is fundamentally from the CDC, with the Department of Health and Human Services being the main player of that. And that really is community engagement at a level very similar to what we did with HIV back when we were doing the clinical trials of prevention and therapy, that we wanted to get the constituency who had skepticism about the federal government getting involved in clinical trials and developing what's called community liaisons and community outreach. That's already being done right now. I'm actually taking part of that in some PSAs and some more broad approaches to that. I think we probably need to do it a little bit more intensively, but it is already on its way to being started.
So I will add a supplemental question, which is in the sort of the behavioral communication system, which is from a 6-year-old from a Yale, a child of a Yale community member, and the child asked, why can't we have more mask breaks at school? And that points to a sort of a more specific but a broader strategy of ensuring compliance from the youngest members of our society.
He said mask breaks?
Yeah, mask breaks. And that's a question from a 6-year-old.
Namely, when you can take your mask off?
Exactly.
Well, that's interesting. That really tells you the stress that goes down to the level of a 6-year-old about, even though masks appear to be easy to do, I mean, it just is a bother keeping a mask on all the time. I do when I'm outside, but I spend most of my time in here and there's nobody around but me, so I don't have it on, but it would be something. But, it is worthwhile bringing up the point that I always say, that this is not going to last forever. And when people feel there's no end in sight, keeping a mask on or keeping a distance or staying out of crowds becomes all the more burdensome. However, if one sees the light at the end of the tunnel, you can say, I could stick this out a little bit longer. So maybe that's one of the messages we can tell the 6-year-old, hang in there. You're not going to wear it forever, I promise you.
Yeah. And if there's any consolation, a lot of adults are acting like 6-year-old. Names should not remain unmentioned. And so, Bob?
Yeah, one of the questions, Tony, you were talking before about the CDC and its role, and I know there's been discussion about that, and I'm not going to ask you about the specifics now. But in going forward, do you think it would be a good idea if the CDC gave out more of the grant money for public health? The NIH gives a lot of it now, and as a result of that, the NIH has a lot of constituents in many states because it goes to many states, and that, as you well know, helps you with Congress. The CDC gives out grants to state and local health departments, but it's a small fraction of what the NIH gives out as grants. Would it be more helpful if more money flowed from the CDC to get them a better constituency in the country?
Yeah, I think that's a very good point, Bob. The CDC, even though they've been somewhat lessened and somewhat maligned during this COVID outbreak, is still an outstanding public health organization. And I think if they did connect a bit more outside with the public health people, particularly in the academic public health, like the schools of public health and places like that, I think that would be not only to their benefit, but to the benefit of the country. I agree with you.
So another question that crystallizes, several questions that are coming from our audiences, but I'll frame it slightly differently. So this country started taking pandemic preparedness a little bit more seriously after anthrax, and especially after the H5N1 scare. And there were a lot of things that were done, and you were at the forefront of a lot of those efforts. But even if you were not directly involved, you were engaged in the broader process. Things like platform technologies and all of that. So that has continued since then. What did we do right? That is, because a lot of discussion has been what we are doing wrong, but there are a lot of things we did right. What did we do right since, let's say, 2005, 2006, that is paying dividends now?
Well, I think one of the things we did right, Dr. Omar, is what you just mentioned. We said in order to prepare for pandemics, we need to do two major buckets. One is to improve our public health capability, be that at the local level or the international uh, uh, global health security agenda and global health security network. We did that right. That's one of the things we did right. But something we did even more right was to focus on things like platform technologies and prototype pathogens, where you actually, and I think our ability to move from the sequence of the coronavirus on January the 9th to a phase 1 trial 65 days later to a phase 3 trial 6 months later is beyond incredible. It's historic in being able to do that. And that was all technological advances in concentrating on platform technologies. That's what we discussed back when you said we were worrying about H5N1 and post-anthrax. We made a decision. We were going to build our public health capacity, but we were also going to focus on doing things in the scientific arena that would better position us. The other thing that I just want to mention is that we've been pursuing is called the prototype pathogen approach. In other words, if you look at flaviviruses, all of the things we've done with flaviviruses, successful vaccines with yellow fever, Japanese encephalitis, and then all of a sudden West Nile comes along. I mean, it's really very interesting how you could learn. We're going to be doing the same thing right now with coronaviruses. We've had 3 pandemics with coronaviruses, nothing until 2002 with SARS, then MERS, and now COVID. If we don't develop a universal coronavirus vaccine, shame on us.
No, I think that's a really good point. Bob?
One of the things in public health communication that can be very difficult is that you have to talk about certain populations, such as incarcerated people who are at high risk both to themselves and to the community members because of the staff and the institutions that take care of them and then go home to their families. How do you convince people that it's a really good idea to maybe consider shortening the sentences of people who are in prison and may end up with a death sentence because of this virus, when that might not be so politically popular?
Well, that's something that we feel strongly about. I mean, I've spoken about that right at the very beginning when we were seeing these major outbreaks in nursing homes and prisons, is that you really want to take a look at the population and say, is this really worth the risk to this person who's in for a nonviolent crime, who's done things like, smoke marijuana or whatever it was that they put him in there? I think we really do need to look at that. It's something that's not in my area of expertise, so I don't want to opine too strongly on it, but it's certainly something that was brought up in our discussions when we knew that there were outbreaks in prisons.
So, a pandemic is just that. It's a pandemic. It's global, etc. And if anything that has shown us the importance of, frankly, global engagement, it is this pandemic. And so moving forward, and we are an Institute for Global Health, Yale Institute for Global Health, which is hosting this event. And we think about this all the time. Moving forward, irrespective of sort of what has happened in the 5, 6, 7, 8 months with the US engagement with the world and WHO, how should we broadly engage global health institutions around the world to address this pandemic, because it is not going away tomorrow, and future pandemics?
Well, I think we need to intensify by several-fold our engagement globally with the global health community, because as you well know from your own position, that there are very competent global health institutions in different countries, not only in the UK and in Europe, but also in Asia and some in South America, all of which we've dealt with. I think we need to very much strengthen our interactions and collaborations with them, because that can do nothing but make our job much easier for the next outbreak, which absolutely is going to come. We keep talking about this, is that it's not a matter of when, if, it's a matter of when. And unfortunately, we're right now in the middle of what's going to be referred to, I think, historically, as the mother of all outbreaks over the last 100 years. And we're not even close to being finished with it yet.
Bob?
So to get back to a specific about treatments, monoclonals looked very good in 2 patients that have been publicized, the governor of New Jersey and the president of the United States. But monoclonal antibodies are not molecules that can be made very cheaply. They have to be made in vats, as you well know. What is the chance for significant production of that form of treatment to an extent that it might be useful? Because there are indications that given early, it could be very useful. Is it ever going to be cost effective and able to be produced widely enough to meet the needs?
Yeah, Bob, I would be disappointed if we can't get over that hurdle. I mean, technically, we can figure out a way to mass produce them. I mean, we've done much more complicated things than that. You're absolutely correct. The way things stand now, you're talking about the availability of hundreds of thousands of doses and not tens of millions of doses. I believe we can get to that. And just a comment about monoclonal antibodies, I think people should be aware that from the standpoint of a mechanistic approach to the therapeutic efficacy of monoclonal antibodies, you really want to give it very early in the course of infection, because we know from experience now with COVID-19 that the virus is very important in the very early days. But, after a period of time measured in several days to weeks, it's the aberrant inflammatory response that gets people into trouble, because if you try and even get virus isolated from people after a week or 10 days, it's sometimes very difficult to do. So if you're going to hit the virus with a monoclonal antibody, you better do it within the first couple of days, which means you have to have it widely available for people to get in an outpatient setting.
Great. So in terms of, there's a couple of questions coming from the perspective of when do you think we will know, or we will reach quote unquote herd immunity, or I think the herd immunity threshold? Would it be homogeneous? Would it be heterogeneous? And similarly, in terms of if you look at the immune landscape at the population level, are there any things we should be concerned about in terms of enhanced disease that you alluded to in the context of sort of vaccine trials, but in terms of infection versus, and on top of that, a mass vaccination program? So anything that we need to think about as scientists, and any questions, research questions that help answer and hopefully mitigate the possibility of enhanced disease, antibody mediated or otherwise.
All right. So you have a couple of really good questions, and they're all together. So let me go through them. First of all, obviously enhanced disease is always something hanging over you as a possibility. There have been some recent experiments done with non-neutralizing antibodies against places other than the receptor binding domain of the spike protein. And they have shown in some really interesting unpublished data not to have any enhancement at all. So even though I think we always need to worry about enhancement, I do think it's much less of an issue than people are making of it. That doesn't mean we're going to discard it, but I don't think that's going to be a showstopper for us at all. Your question about herd immunity, we can guess what the percentage of people who are immune to give so-called herd immunity. I don't know what it is. I say, 70, 75, 80% of the people as a good guess. It's not 20%. It's not going to be 20%. So how do you get to herd immunity? Well, you get to herd immunity by getting people immune one of two ways. They either get infected, they get vaccinated, or a combination of both. If we're relying on infection alone, the disease and death burden to get 70% of the population is unacceptable completely. So it's going to have to be a vaccine that's at least modestly effective. And when I say modestly, I mean 75%. I'd love a 90%, but I'm not sure we're going to get there. With wide uptake of the vaccine, which gets back to our conversation a little while ago about getting people who are reluctant to get vaccinated. And finally, buried in there, a source of anxiety for me is what is the durability of the protection? So herd immunity is great as long as you're immune. We may need to come back with boosters if the durability of the protection is not very good.
Yeah, I think those of us who work on vaccines related questions are looking at an employment security kind of a scenario for the next few years. And I say that in jest, but there are a lot of questions, interesting questions that will not only inform this pandemic's response, but vaccinology more broadly. If I may go to sort of another question, and then we'll ask Bob to sort of add any other questions. So looking at your role as a major scientific leader, would love to hear, how does NIAID and how does NIH change and the broader scientific enterprise change after this pandemic? What do we do different going forward? And so I don't know if you have thought about it or if you have any perspective on that.
Well, I think what this I don't want to speak for NIH as a whole, except for one aspect of it, but particularly with regard to infectious diseases and outbreaks. I think what we learned from this outbreak, what NIAID might change, is just not necessarily change, but underscore the reality that outbreaks have always occurred. They are occurring now and they will continue to occur. So even though you need to make an investment in established infectious diseases like tuberculosis and malaria and HIV, which not too long ago was an emerging infectious disease. Now it's almost a 40-year established infectious disease. So we've learned that. The other thing that we've learned is how quickly you can turn on a dime, and it may change that, which is the importance of being able to supplement grants quickly and get investigators who are not involved in something involved in it. It's amazing how both intramurally and extramurally, we have people in my own lab who've been doing HIV for the last 25 years are now looking at glycosylation of spike proteins on COVID. So it's really very interesting how people can quickly change on a dime and do really important things in an area that they weren't expert in.
Yeah, no, so it's been fascinating to see, mostly positive, that people have switched from, HIV research, influenza, in certain cases, radiology, neuroradiology, specifically to being infectious disease experts. Most of it is good. I think I can say that confidently. Exceptions apply. So Bob, I'll give you the last questions and then I'd be happy to wrap up.
Okay, well, here's one last question. Tony, you have answered an astounding amount of questions in the last weeks and months, beyond belief. Is there anything you wish you had been asked that you haven't been asked?
Is there anything I wish? I think I have actually, Bob, been asked virtually every possible question. I cannot think of something that I would have said, gee, this is silly. Why didn't they ask this question? And I would think the reason for that, Bob, is that we're really living. I think right now we almost don't realize it, but when this is over, which it will end, I keep telling people that, particularly younger people who seem frustrated, this is going to go on. This will end. When we look back at this is really going to be an incredibly historic experience that we've all been through. And I hope there are going to be some important lessons that we learn from this about what we've done right, what we haven't done right. But I think, in answer to your question, I think I've been asked virtually every imaginable question many more times than once.
And just very quickly, Saad, and I'll give it back to you to conclude. But from the volume of questions that have been submitted by the audience, I think nothing sparked more palpable reaction than your use of the year 2022 in thinking about a possible end to this. How do you reassure people to keep going, to keep up and have faith?
Well, I think it's going to be, because it's going to get better and better gradually. It's not going to be horrible until the end of 2021. Once we get the vaccine mobilized, once we get that baseline level of infection down and get people to fully appreciate and realize that you've got to do some fundamental public health things to keep this infection rate down, I think people are going to start to see, kind of like the sun coming up, a little bit of light, a little bit more, all of a sudden there's a bright sun there and hey, we're out of it. I think that's what's going to happen.
Great. So thank you for an enlightening conversation today. And I know that, the excitement of your family being excited about you being on TV goes away after the first 4 appearances. For you, the point was crossed in the 1980s, probably. After that, it becomes a distraction for a working scientist to go out and communicate again and again with people with varying level of receptivity, be it expert audiences or academic settings or the general public. But this is important, and thanks for recognizing that. Thanks for continuing to be productive as a scientist and being a communicator. So you have set a high benchmark for everyone else. So, people would get their tenures, they'll become their national academies membership. Then there will always be the bar to appear on a cupcake. That will be hard to meet. So thanks for setting that bar for the community and being an example. And I appreciate you being here. And for the audience, just to remind everyone, the next one of this series on November 11th, with Henrietta Fore, who's the executive director of UNICEF, where we learn more about their trailblazing work in child health, both broadly and in the context of COVID-19, because children have been disproportionately impacted, not by the disease as much, although by the disease as well, but the pandemic as a broader social concept. By perhaps, they're one of the top most affected groups in terms of development and education, et cetera. So stay tuned. We'll see you on November 11th. And thanks again, Bob, for co-moderating, and Dr. Fauci for taking time to be here.
Thank you very much, Dr. Omer. I appreciate you having me. And Bob, it's always great to see you, my friend. Take care.
Yeah, indeed.